So we had discussed in the last lecture about multiple sclerosis again and chronic inflammatory autoimmune disease, and today we are going to see another disease which is termed as an MND, motor neuron disease. Yeah. So motor neurons, as you know, as the name itself suggests, these are the nerves, or these are the whole neurons. Neurons are the basic and structural and functional unit of nerves. Yes. So those nerves which supply the motor aspect mainly will be included in motor neuron diseases. A famous personality, as you are seeing on your screen, had this disease. Yes, can someone tell me who is this personality?
Stephen Hawking.
Stephen Hawking. Yes, very true. A great scientist, a great teacher, philosopher. Yes, and he suffered from this disease. Is this disease specifically, patient will come to you very healthy. Whenever it is diagnosed, the patient will be able to do many things. They may be able to walk, may be able to do all the ADLs, activities of daily living, and even work. Yes, but as time goes on, yes, this disease becomes so life-taking, and ultimately the patient will die. Yes, so you cannot help, but the patient has to die, will die in probably 2 or 2.5 years. Yes, once the diagnosis is confirmed, patient will die in 2 to 2.5 years of age. So the prognosis already, I am telling you, it will be worst. Yes, the patient will die off no matter what treatment, no matter what medications they take. Specifically, they will not be surviving. So we are starting with motor neuron diseases. Yes. So what are motor neuron diseases? Involves all the disease that involve the selective loss of all functions of the upper and lower motor neurons innervating the voluntary musculature of the limbs and bulbar region. So again, as the term bulbar, 9, 10, 11, 12, lower 4 cranial nerves. Yes, whenever bulbar term comes, it is lower 4 cranial nerves that we have to think of, and all the voluntary musculature. So only and only exclusively your motor nerves will be affected, as the name itself suggests. Yes, it can be upper motor neuron, it can be lower motor neuron. Now motor neuron, as we are talking about motor, yes, so that originates specifically from the spinal cord. Yes, so brain will be relatively spared. Only and only spinal cord affection you will be able to see, but lower aspect, the brainstem level, can be affected. That is why there is bulbar region affection. And in this, one specific disease that is in your syllabus, that is amyotrophic lateral sclerosis. Yes, as the name suggests, amyotrophic. Yes, all the muscles will be affected. Myotrophy, yes, related to muscles. A means denervation. Lateral sclerosis. Lateral means lateral aspect of the spinal cord will be affected. That is responsible for carrying your descending pathways. And sclerosis, yes, gliosis, as we had discussed, patches તમને જોવા મળશે, as we had seen in multiple sclerosis. So that sclerosis are patches that you see on MRI. Spinal cord ma same condition. Yes, પેલા infection થશે, that is one of the risk factors. Infection na લીધે autoimmune response આવશે. Autoimmune response na લીધે there will be affection in the spinal cord. Yes, the only differentiating feature between multiple sclerosis and ALS, amyotrophic lateral sclerosis, is that affection of only and only motor part in ALS, while in multiple sclerosis there will be sensory, cognition, other functions also affected. Amyotrophic lateral sclerosis ma higher mental functions will be normal. Yes, that is the main differentiation between multiple sclerosis and amyotrophic lateral sclerosis. Even Guillain-Barré syndrome and amyotrophic lateral sclerosis sometimes can become equal. Yes, so how will you differentiate? GBS is a progressive, yes, ascending progressive paralysis, but amyotrophic lateral sclerosis will not be progressive in that sense. Ascending progression nahi hoy. Yes, it is affecting only specifically few muscles. Which are those muscles we'll also be discussing. So amyotrophic lateral sclerosis, first described in 1897, referred to as Lou Gehrig disease because the scientist was Lou Gehrig. according to his name. On his name itself, we are naming the disease Lou Gehrig disease. So whenever even in exam it is asked what is Lou Gehrig disease, it is amyotrophic lateral sclerosis, which is type of motor neuron disease. It is a progressive neuromuscular condition characterized by combined upper and lower motor neuron signs. Yes. So spinal cord is affected. In the last lecture for multiple sclerosis, we had described what is UM and what is LMN. So whenever a part of the spinal cord is affected at the interneuron level, above it is affected, that is UMN type, below it is affected, that is LMN type. Yes. So in amyotrophic lateral sclerosis, both are possible. Yes, signs of UMN plus signs of LMN. Yes, so that is why it causes denervation of muscles also. Epidemiology, how much common is it? So 1 to 2 cases per 1 lakh you see. Yes, 1 to 2 cases per 1 lakh of population is affected worldwide. Males are more affected than females, 2:1 ratio. So males are more likely, double likely to get this disease compared to females. 90 to 95% are sporadic. Sporadic means they have no history, no hereditary condition, they have acquired this condition. Yes, from the environment this condition is acquired. So that is termed as sporadic. 5 to 10% is inherited. Inherited means father, grandfather, mother, grandmother, and all those linkages are there. So there will be death whenever you ask the patient in history part. Yes, in the assessment, when you ask the patient, has anyone died because of this disease or has anyone been diagnosed with such a disease? Probably their answer will be yes, if they belong to this 5 to 10% of the inherited population. Baki 90 to 95% is first time, always first time. Yes, that is acquired, not genetic. Onset, mainly it is after 40 years. So as the age increases, chances of getting ALS also increase. Yes, so increase with the age. Mostly it will affect the people with more than 40 years of age. Etiology. Mostly we don't know the etiology, what is causing this disease. Yes, but it can be multifactorial. It can be genetic, as we talked about, 5 to 10% hereditary. Viral, yes, it is always related to an infection, and after this that is an autoimmune response. And at the last there can be neurotoxicity hypothesis, like the patient is consuming some neurotoxic materials. Yes, so because of this there will be affection. Risk factors, yes, directly trauma over the spinal cord. Spinal cord ne jo trauma thoy, to pan there are chances you will damage the motor neurons and you will start the autoimmune process, and that will lead to again amyotrophic lateral sclerosis. Long bone fractures. Fractures can lead to often injury to the nerves, and that can again lead to ALS, autoimmune response to the nerves. Manual work, overwork, yes, overuse of any part can cause such a disease. Occupational exposure to toxin, lead, and solvent, because these are the neurotoxic substances. Yes, excessive amount of toxins, lead, and solvents. This will lead to increased autoimmune response. And last is certain food items. Now that is specific to allergic items for an individual. If a patient is taking allergic items, there are chances it will cause neurotoxicity. Yes, because the body is already not adapted to consume such amount of food. So because of this risk factors, there will be any of this can be possible. That can be genetic, that can be viral, it can be autoimmune, and last will be the neurotoxicity. Because of this, there will be amyotrophic lateral sclerosis. Pathology. So first and foremost, loss of large motor neurons in spinal cord and brainstem. Yes, as we talked about, brain will not be affected, brainstem will be affected, bulbar effect. Yeah, and spinal cord completely will be affected. Yes, so large motor neurons will be affected. So all the origins of the motor neurons will be affected. Gliosis. Yes, what is gliosis? We had described in multiple sclerosis. What is gliosis? Gliosis એટલે શું? In the last lecture we had described. Not ulcer, no. What is gliosis? In multiple sclerosis, we saw in the pathology also, if a nerve is damaged and it is not healed, then what is formed? Scarring of nervous tissue. Very true. Yes. So this scar formation is termed as gliosis. When it is seen in multiple sclerosis, it will be in the brain as well as spinal cord. Here, gliosis is exclusive to spinal cord and brainstem, not over the brainstem level in the brain. Yes, so if it is present in the spinal cord, it is gliosis is present. That is more, and you will be sure that it will be example of an MRI of an amyotrophic lateral sclerosis. Spheroids, that is interwoven disorganized neurofilaments in proximal axons. Yes. So sphenoids is nothing but a structure. Normally, our neurons, axons are continuously and organized in a way that they are in a single sheet, you can say. एक organized way हसे, एमा ज axons हसे. But when gliosis happens because of the scar tissue, the structure of the axon is altered. So interwoven disorganized neurofilaments in proximal axons are seen. Now, this is purely based on histological studies. Yes, you take a, you can say, a specimen, body part, from where you extract some portion of the axon, some portion of the nerve, and you observe. Then you will be able to see spheroids. Yes, so this is again a test not so performed very regularly, but this is the pathology that we can find. 1/3 of motor neurons destroyed before the muscle atrophy becomes apparent. Now here main pathology ક્યાં છે? Spinal cord માં, nerves માં. Yes, તો spinal cord અને nerves atrophy થવા માંડે, gliosis ના લીધે scar formation થવા માંડશે, તો nerve conduction velocity ઘટવા માંડે. muscle સુધી signal પહોંચાડવાની જે normal speed છે એ decrease થઈ જશે. Yes, so muscles will be affected in the later stage. તો muscles જ્યારે affect થશે ત્યારે almost 1/3 motor neuron તો destroy થઈ ગયા હશે. Yes, તમને દેખાશે કે muscles are now becoming atrophied, that is decrease in their tone. Yes, decrease in the girth. At that time already there will be 1/3 motor neurons will be destroyed. Peripheral nerve shows secondary degeneration of axons and myelin. Yes, because of degeneration that is present, axons and myelin also become slowly and steadily worn off. Yes. Surviving motor neurons develop collateral branches. So as much as motor neurons are present, their dendrites try to extend. Yes, axons cannot regenerate, as we had talked. Axons ekવાર damage થઈ ગયા, they cannot regenerate, but the dendrites can. So dendrites, they try to move and try to innervate more amount of other nerves so that the function can be saved. Yes, function save કરવા માટે it will develop collateral branches. એટલે એકમાંથી બીજામાં directly જે connection છે, they will try to bypass and move to the third neuron. Yes, so that is collateral branches. And atrophy of the degenerated muscle. Yes, so completely in later stages you will be able to see degenerative changes in the muscle. Yeah. Prognosis, average survival is 3 to 5 years after the onset. Yes, once the disease starts, once signs and symptoms start, maximum the patient will be able to survive is 3 to 5 years. Yeah. Death occurs from respiratory failure or respiratory insufficiency. As always, we have seen in GBS also, we have seen in multiple sclerosis also, it is the complication of cardiopulmonary system that leads to death of an individual. Yes, the same thing applies to patient with ALS also. Bulbar onset, if cranial nerves are affected, lower 4 cranial nerves are affected, there are chances that the prognosis will be worst. The survival time will even be shorter. So 20 months is the median survival. You can see 20 months. It is less than 2.5 years. 5% survive 5 years after the onset. Spinal onset, 29 months in the median survival. 15% survive 5 years after the onset. And luckily, Stephen Hawking was one of them who survived with a spinal onset more than 7 years. Yes, so he was an exception from the disease. Very few people are able to survive more than 5 years. Short survival is associated with greater age. Yes, as the age increases, chances of getting worse are more. Yes, because normally पण age na lidhe there are various changes in the nervous system, in the whole body. Yes, may that be musculoskeletal system, may that be vascular system, cardiorespiratory system. All these systems they have age-related changes. You have learned in physiology. Yes, the same thing with that along with the disease. Any સાથે disease પણ છે. So there are chances with greater age, short survival is common. Low person predicted vital capacity, FVC, forced vital capacity. Yes, so forced vital capacity is forceful inhalation and forceful exhalation. Whatever the percentage is, that is vital capacity of that individual. So that also becomes lower. So if the patient is having forced vital capacity lower, then there are chances the patient will not survive longer. Lower serum chloride, short interval from symptom onset to diagnosis, and greater weight loss. So all these symptoms, if they are present in an individual, serum chloride helps in your normal transport also of the nerves. Yes, whenever the signal is transferred, they play an important role. So for that reason, serum chloride, if it is lower, nerves will be damaged more and more. There are chances the patient will not survive, the condition will get worse. Short interval from symptom onset to diagnosis. So symptom onset થયા અને તરત જો diagnose થઈ જાય, that means you are going to see the patient for up to 3 to 5 years of the onset only. Yes, that is a predefined timeline for that individual with ALS. And greater weight loss, if there is a significant amount of weight loss, that is there is poor nutrition that the patient is undertaking, there are chances he or she will not survive. Poor prognosis for survival. Clinically, you see increasing age, prominent recent weight loss, short time for onset to diagnosis, rapid rate of strength and respiratory loss during the 6 months after diagnosis. Yes. So normal strength, the patient is coming to you, you are checking their strength and respiratory capacity. In 6 months, you see it is decreased significantly. That means the patient is deteriorating. And yes, because of this, the patient will not survive longer. Respiratory failure and no gastrotomy. Yes, if the patient is not able to take the food directly, at that time gastrotomy is needed. But if the patient has not done any gastrotomy, if they are taking the food and the nutrition, you can see the weight loss. At that time, it is a sign of clinical poor prognosis. Laboratory, you see poor pulmonary function, as we already described, less than 60% of predicted. Predicted is what? Normally, say for example, an 18-year individual male, yes, and with the height of 6 feet. Yes, so it is predefined that this will be the vital capacity, which this will be the tidal volume, this will be the other parameters of volumes, lung volumes. Yes, but if it is altered, if it is changed, that is termed as change in the predicted values. These are the predicted values. This is done from data collected from various individuals. Yes, 18 years ના ઘણા બધાને સાથે લીધું હોય, એનો ડેટા લીધો હોય, પછી એક mean value decide કરી હોય. Yes, average decide કરી હોય કે this is normal requirement for this specific age, for this specific gender, and for this specific height. Yes, so if this is altered, that is change in the predicted values. So if it is less than 60% of the predicted values, laboratorily we can say there are poor prognosis for survival. Serum chloride, as we already talked, if it is failing in relation to poor nutrition. So nutrition is altered, because of this the iron will be deficit in the body. EMG, just remember EMG, no need to remember the compound motor action potential or anything. If you wish to know, compound motor action potential is something that you obtain on a screen of EMG. Yes, that is you try to stimulate the nerve and you try to obtain the response on the screen. Yes, that is EMG. So that is CMAP, compound motor action potential. Decrement on RNS. RNS is nothing but repetitive nerve stimulation. You try to stimulate the nerve again and again with the machine, of course, and you see a decremental response. Decremental response is તમારું response જે muscle કરતું હોય normally, with time you can perform 10 push-ups, say for example. Yes, from 11th push-ups, 12th push-ups, your strength starts to decrease and you become fatigued more and more. But here the nerve is already affected. અહીંયા nerve જ affect થાય છે. Yes, peripheral nerve of spinal cord is affected. So શું થશે? 2 કે 3 push-up કરશે patient, ત્યાં જ એને fatigue feel થવા માંડશે and motor response will be decreased. Yes, so that is termed as decremental response on RNS. Homogeneous deletion of SMN2 gene 5. Now this is a specific gene that people and scientists have found from the studies. So SMN2 gene 5, remember this, this can also be asked in MCQs. SMN2 gene 5 is responsible for ALS. Yes, more common in sporadic ALS, that is acquired, which is 90 to 95%. Yes, 5 to 10% is hereditary. In the first part we already saw. Survival times 2 years short. So if this gene is affected, SMN2 gene 5, normally if it is 5 years for an individual to survive after diagnosis, 2 years minus kari devana for that individual. Yes, only 3 years they'll be able to survive. Coming to clinical presentation, what all things do you observe in a patient with such condition, ALS? So, as we already know, there is affection of UMN as well as LMN. Yes. So, for UMN signs and symptoms, there is weakness, there will be spasticity, there will be hyperreflexia, there will be extensor plantar response, that is Babinski sign will be positive. For LMN signs, there will be weakness, wasting, and fasciculation. Fasciculations are nothing but because of too much decrease in the muscle strength, you sometimes see it's flickering. Flickering is contraction, relaxation, contraction, relaxation. Yes, that is termed as fasciculation. When the muscle becomes too weak, yes, it cannot maintain a specific tone also. At that time, it contracts and relax. Yes. So UMN sign, first there is weakness. The weakness is sign of both UMN as well as LMN. Spasticity, yes, spasticity is there. Hyperreflexia will be there, and positive Babinski sign, that is extensor plantar response. LMN sign, weakness, wasting, and fasciculation. Now next is cachexia. Cachexia is a, you can say, general state of ill health involving marked weight loss and muscle loss. So overall, bow vadare weight loss thai jai and muscle loss specifically if it is there, then you can say the patient is suffering from cachexia. Yeah. Specifically seen in ALS. Also, there is one other condition that we are going to discuss. Motor neuron diseases. Except motor neuron diseases, we are going to discuss about the muscular dystrophies. So in that also, again, we'll be discussing the term cachexia. You will come across the term in muscular dystrophies. No sphincter or sexual disturbances. Cerebellar signs will be there. Yes, because brain stem is affected. Sensory changes probably will never be there. Cognitive changes will never be there. Oculomotor dysfunction will never be there, and autonomic nervous system will be normal. Yes. So all this, if they are present, any one of them is present, that means it is not ALS. Yes. Sphincters or sexual dysfunction will not be there. So urinary bladder function will also be normal. Cerebellar signs will not be there. Only brainstem signs will be positive. Sensory changes will never be there. It is exclusively termed as a disease નું નામ છે motor neuron disease. So no sensory affection. Cognition will not change. Brain is not affected. Cerebrum is not affected. Frontal lobe is not affected. So cognition should not be affected. Oculomotor dysfunction will not be there. Optic nerve as well as the eye, all the muscles of the face will not be affected. Autonomic nervous system will not be affected. Yes, because it is not affecting the sensory part or the autonomic part, it is only affecting the motor aspect in the spinal cord specifically. Okay, if you want to summarize all the signs and symptoms of lower motor neuron and upper motor neuron type of diseases in seen for CNS regions: brainstem, cervical, thoracic, and lumbosacral. So which are the lower motor neuron signs like weakness, atrophy, fasciculation? You will see in jaw, face, palate, tongue, larynx. For cervical region, neck, arm, hand, and diaphragm. If diaphragm is affected, as you already know, respiratory affection is there, the patient will not be able to survive. Thoracic, muscles of the back and muscles of the abdomen, all the extensor muscles of the spine as well as the flexor muscle or the abdominal muscles. Lumbosacral, back muscles, abdominal muscles, leg and foot also will show signs of atrophy. Yes, muscles will show sign of atrophy. Jyare atrophy avse ત્યાં સુધી already 1/3 of the motor neuron will be damaged, will be lost. Yes, so it is irreversible. Upper motor neuron signs. Yes, so first for brainstem there will be clonic jaw. Clonic, clonus is again something we described. in the pathological reflexes. Yes, you try to move the part into contraction and then relax. There will be to and from motion, contraction and relaxation. That is clonus. Yes, so if you open the jaw to a slight amount of motion and you release it, there will be continuous motion of the jaw. It will close and open. Yes, so that is clonic jaw. Second, gag reflex. Yes, we have already seen what is gag reflex. It is normally seen with 10th cranial nerve. Yes, so if 10th cranial nerve is affected, brainstem is affected because of this bulbar involvement. 9, 10, 11, 12 cranial nerves are affected, and because of this, there will be deficit of gag reflex. Exaggerated snout reflex. Now, if we talk about specifically, just a second. Yeah, so snout reflex is something most of you will be knowing. You are performing on every day, uh, doing pout movement. Yes, pouting of the lips is something that is termed as snout reflex. Yes, why does it happen? It is elicited by light tapping on the closed lip near the midline. So near the midline of the lips, if you close, if you tap, for a small children, of course, but you also are doing, so it may be present in you also. So snout reflex that is present, that is exaggerated. Pseudobulbar effect, you already know pseudobulbar effect, abrupt crying or laughing loudly without any reason, that is pseudobulbar features. Forced yawning, yes, the patient tries to yawn forcefully as much as possible. It happens, you might even experience this normally also, but in this patients it will be a common sign that you will see. So many a times when you yawn, you are not satisfied. Yes, you feel like, no, I should do it again, I should do it again, unless and until you feel, yes, now it is okay. Yes, bagasu ave, but you are not satisfied with that. It was not enough duration, it was not enough length, whatever the reason may be. But then what you perform is forceful yawning. Yes, you force yourself to yawn. So that is again a brainstem lesion sign. In normal also this can happen once 15 days, that is fine. If it is happening very frequently, you should get an MRI done. Yeah. Pathological deep tendon reflexes and spastic tone. Yes, pathological deep tendon reflexes, exaggerated reflexes will be there, more than 2+ grade in the scale that we have already described during assessment, and there will be spasticity checked through modified Ashworth scale. For cervical region, clonic deep tendon reflexes will be there. Hoffman reflex will be there. Pathological deep tendon reflexes, spastic tone, preserved reflex in weak vested muscles. So whichever muscles are affected, e muscles mass specifically, you can see the exaggerated, preserved reflexes. જે muscles weak છે, જે muscles atrophied થઈ ગયા છે, એમાં exaggerated નહીં આવે. Why? Because the muscles and the nerves, the complete pathway is affected. Pathway affect થશે તો exaggerate નહીં થાય. Spasticity હશે જ્યાં સુધી muscles માં, ત્યાં સુધી yes, you will be able to see more of exaggerated reflexes. Talking about Hoffman reflex, so Hoffman reflex is seen specifically in upper extremity. Yes, so you hold the middle finger and flicker the finger nail downwards. Yes, so fingers hold karwani, middle finger specifically, and you try to move the finger downwards, that is specifically at the DIP region. DIP joint tame flex karwani try karso, that is the main elicitation sign. So what will you see? It will it will extend reflexly. Yes, so e extend thase and it will remain flexion extension je clonus આપણે જોઈ છે in the deep tendon reflexes, specifically for the jaw we saw in the brainstem. The same thing you will be able to see for upper extremity, and here you see for the middle finger. So middle finger તમે flex કરશો, try to hold it and then relax. So reflexly શું થશે? E extension flexion માં DIP region just it. DIP joint will go for extension and flexion. So this is termed as Hoffman reflex. Again, there will be clonus and pathological deep tendon reflexes. There will be spasticity also. In thoracic region, for UMN lesion, loss of superficial abdominal reflexes, pathological deep tendon reflexes, and spastic zone. So here, abdominal muscles are affected. Because of this, there will be loss of the motion, that is loss of complete reflexes. Lumbosacral region, clonic deep tendon reflexes, extensor plantar response, that is positive Babinski sign. Pathological Pathological dependent reflexes, spasticity will be there. Preserved reflex in weak vested limb, same as for upper extremity. Yes, tapered muscles એકદમ weak થઈ ગયા છે. For example, calf muscle is completely atrophied. તો તમે એને dependent reflex try કરશો, ankle jerk લેવાની try કરશો, then also there will not be much response. Yes, it will be decreased response or normal response also, you can say. Okay, for the diagnosis part, we'll just go through it, that which are the signs that are compulsory to define ALS. એટલે આ patient ને 100% ક્યારે કહી શકી કે probable કે possible ક્યારે કહી શકી કે આમને ALS છે. Yes, so the first definitive કે 100% ALS છે, you can say when UMN and LMN signs in 3 to 4 regions. So for all the 4 regions, 3 to 4 regions ma LMN and UMN sign, any one or two signs are present of LMN or UMN in 3 regions, then you can say the patient is completely definitely having ALS or evidence of progression. Yes, so situation or condition becomes worse, as we already talked. Patient સાજુ આવશે તમારી પાસે and later on the deterioration will happen, so condition will progress. So if there is evidence of progression, then also it is definitely ALS. Probable, maybe. Yes, so LMN and UMN signs in at least 2 regions with UMN, above LMN signs and evidence of progression. Yes, so LMN and UMN sign in at least 2 regions. Bay region ma, yes, out of the brainstem, cervical, thoracic, lumbosacral, LMN UMN signs Bay region ma ક્યાંય પણ હોવી જોઈએ. With UMN above LMN signs and evidence of progression, એટલે UMN LMN કરતા UMN ની signs થોડીક વધારે હોય, that is suggestive of ALS. Possible, yes, 50-50. So LMN UMN in one region, કોઈ પણ એક region માં UMN and LMN signs છે. UMN in 2 regions, LMN above UMN sign, UMN જો વધારે હોય, sorry, LMN વધારે હોય UMN signs કરતા, and UMN in more than 2 regions is seen. LMN UMN signs but no evidence of progression. So if progression is also not there, then it is 50-50. Maybe ALS, may not be ALS. And last suspected, that is the least 25%, you can say, LMN sign in 2 to 3 regions. Yes, so only LMN signs in 2 to 3 regions, you can say probably the patient, or least suspected it will be that it is ALS. Yeah, but if there are these changes, then these are negative features. Yes, જે આપણે starting માં પણ વાત કરી clinical features, these things should not be there. Yes, આ હશે, then 100% the patient is not having ALS. So finding inconsistent with diagnosis of ALS, which are there: neuroimaging, EMG, clinical or other evidence of an alternative disease explaining the sign and symptoms. So directly તમે ખાલી clinically જોયું તો એમાં તમને ALS લાગતું હતું, પણ cervical plus brain માં પણ injuries છે. You can see the sclera. Yes, so you can say it is multiple sclerosis. So from neuroimaging, that is MRI or EMG, or clinically other evidence of disease. Yes, કોઈ બીજા જ disease ના તમને evidence મળી જાય આ ત્રણ માંથી, neuroimaging, EMG or clinically, then you will say this is not ALS. Lack of progression to other body regions. Yes, so if body regions are affected other than this 4 regions specifically, say for example face is affected more, only face is affected, the other 3 are not affected, that time you can say yes, this is not ALS. Cognitive decline, as we talked about, cognition will never be affected, sphincter will never be affected, sensory dysfunction will never be there, and visual decline will never be there. Yes, all the things we had discussed here itself in the clinical presentation: sphincter, cerebellar signs, sensory changes, cognitive changes, oculomotor dysfunction, autonomic nervous system, this will never be affected. આ કોઈ દિવસ affect નહીં થાય ALS માં. જો થાય છે, that means it is not ALS, it is some other disease. Yeah. Okay. Main diagnosis and treatment part, we'll keep it for next lecture. Yeah. Any doubts so far anyone has? Please reply in the chat. Okay. Fine. In the next lecture, we'll be able to complete this also. but as I had already discussed, this condition will not be included in your CE. Yes, all other conditions are included in exam. Yes, ALS will not be clear. Up to multiple sclerosis it will be included. I have shared the presentation already, I guess, in the classroom, so you have all the material. I have written references for all the things at the end of the presentation also. You can go through them and you can find the books itself. Yes, from the books itself you have to read and write in the exams. ALS will not be included in the exams. Okay. Purva, have you taken the attendance?
Yes, sir.
Okay, fine. So we'll keep it till here. We'll meet again probably tomorrow and we'll try to complete. And if possible, if we have 2 lectures, we'll try to again start also a new condition. Yes. Okay. Hope you have a good day.
સર
Yes, yes, Purva.
સર એક્ઝામમાં મતલબ કેટલા માર્ક્સના કેટલા ક્વેશ્ચન હશે?
You are not given the format.
સર એક જ સબ્જેક્ટનું